Good afternoon, everyone. My name is Brittany Starks, and I'm Communications Director for Debbie's Dream Foundation. Thank you for joining our webinar this afternoon. Before we begin, I'd like to take a moment to thank our sponsors for this event. Our platinum sponsors, Amgen, Daiichi Sankyo, and Merck. Our silver sponsor, Bristol Myers Squibb, and our bronze sponsor, Seagen. During today's webinar, you can type your questions throughout the presentation into the chat section that appears in the webinar menu. We will address questions after the presentations as time allows. I will now introduce today's moderator, Dr. David August. Dr. August is a surgical oncologist and associate director for faculty affairs at Rutgers Cancer Institute of New Jersey. Since his training as a resident and as a fellow at the National Cancer Institute in Bethesda, Maryland, Dr. August has had a strong interest in cancers of the esophagus, stomach, pancreas, colorectum, and retroperitoneum. He also pursued clinical and research interests in nutrition and cancer prevention and the treatment of advanced esophageal and pancreatic cancers. Some of his long-standing research has been on using food-based agents to prevent cancer on the use of vaccine therapies for pancreas cancer. Dr. August has experience and expertise in surgery for esophageal cancer, Whipple procedures, and other surgeries for the pancreas and rectal cancer. He works closely with a team of genetic counselors to evaluate and advise patients with a strong personal risk of gastrointestinal tract cancers because of a family or personal history. He is the author or co-author of more than 90 publications as past president of the American Society for Parental and Internal Nutrition. He serves on the editorial board and peer-reviewed groups of many professional journals. Dr. August, welcome, and thank you so much for joining us today.
Thank you very much, Brittany. On behalf of Debbie's Dream Foundation and my colleagues here at the Rutgers Cancer Institute in New Jersey, I'd like to welcome all of you to this webinar. It's our pleasure and privilege to be able to present to you today and to have been able to assemble this, what I think is a really fine group of speakers. We will be available for questions at the end of the webinar, so please save your questions up until then. Our first speaker is Dr. Miro Grandi. She's a valued colleague of mine, went to Indiana University School of Medicine, and then completed a surgical residency at the University of Colorado before going on to Johns Hopkins for her surgical oncology fellowship. She's been with us, I think it's 5-6 years now, and as I said, has really become a valued colleague and friend. Today she'll be speaking with you about minimally invasive surgical approaches to gastric cancer is less better. Dr. Grandi?
Thank you, Dr. August, and thank you all for having us today. It's a pleasure to be here and talk to you about minimally invasive surgical approaches to gastric cancer. The real question is less better. Next slide, please. So I have no disclosures, just meaning I really have nothing, no added personal benefit to talk about minimally invasive surgery, besides I do find some value in it. Next slide, please. There's just a little bit of background about gastric cancer. Since I am the first speaker, I just wanted to give some statistics. So this year, there are expected to be roughly 26,380 expected new cases of gastric cancer in the United States. And in terms of the expected deaths from gastric cancer in 2022 in the US, there's expected to be roughly 11,090 this year. The images to the right basically indicate that over time, if you follow that green line, that's the death per 100,000 males and females in the United States. And as you notice on that green line, the trends are going down. And I think that's basically a sign that we're treating gastric cancer a little bit better than we were back in 1930, especially for females. I mean, in males, it's slightly down, but I think that's more of a sign of what we're doing both surgically, but also from a systemic chemotherapy standpoint. And so just a little idea of what we're doing over time with gastric cancer. Next slide, please. So just to talk about the stages of gastric cancer, as all of you may or may not be aware, we stage each cancer to give an idea of how aggressive it is or at what point, where we are in the stage of that cancer. It's really categorized by the T category, the N category, and the M category, and that gives you the actual stage of the cancer. Stage 1 is very early. Stage 4 means it's spread to other organs, and in between there we have various aspects of gastric cancer. So the T category really talks about how deep into the wall of the stomach the cancer has grown, or the surrounding organs it may be involving. The N stage talks about the lymph nodes that are nearby, and these may be all terms that you have heard or may not be aware of. And the M category demonstrates whether it's spread to other organs that are separate from that area, such as the liver. Next slide, please. So when we talk about surgery, we talk about 3 main approaches. We talk about open surgery, which is basically making an incision, a large incision, and doing the operation through that. We talk about laparoscopic surgery, which are using instruments while we're at the bedside, and we're navigating those instruments that are doing the surgery through small little incisions. And then we talk about robotic surgery, which are basically small incisions in the patient's abdomen while the robot is in the abdomen, and we're controlling it at the just in the same room at a different surgical console, which I'll get into in a minute. Next slide, please. Next slide, please. And next slide. So back one. So when we talk about laparoscopic surgery or robotic surgery, we're referring to those types of procedures as minimally invasive surgery. And basically what that means is that we're using these small incisions to accomplish the same operation we would accomplish through a larger incision, but we're trying to kind of save some of the incisional pain for the patient by doing it through these small little incisions. Next slide, please. So surgery, just to kind of get us up to speed on the terminology, when we talk about a partial gastrectomy or a subtotal gastrectomy or a distal gastrectomy, we're talking about a tumor that is at the end of the stomach. So you can see there the stomach is a large organ, and the tumor is really at the very end of the stomach before the small intestine begins. And there we could take just the very end of the stomach and reconnect it to the small intestine to allow the food that we eat to go down, as the arrow indicates on part B of the image to the left. Now going to the image on the right, that's a total gastrectomy where we remove the entire stomach and bring up a loop of small intestine and connect the two. And so it is a more involved operation and a little bit riskier than a subtotal gastrectomy, but you know, people often ask, how am I going to eat? How am I going to be able to eat again if I don't have a stomach? And we do, you know, that loop of intestine does stretch out and accommodate more food over time. And so that's just kind of to give you an idea of the terminologies. The subtotal gastrectomy is a little less involved than a total gastrectomy. Also, something to just briefly mention is, you know, if the tumor's up here, some people I'm sure are wondering, why can't you take the end of the stomach and just, instead of taking out the whole thing, take the end of the stomach and reconnect it to the esophagus? And we find is that the stomach just doesn't function as well, and that's why we don't do that operation routinely, though there are some groups throughout the internationally that are looking into that a bit further. Next slide, please. Okay, so just I should have warned you, if anyone gets queasy, maybe turn your head for a little bit. But open surgery requires making an incision generally from the bottom of the breastbone down to the belly button. And then on the right side, you see basically we've exposed everything. We can see everything very clearly. You see the pancreas there that sits behind the stomach. You see the stomach there. The esophagus is the end of the swallowing tube, which then turns into the stomach. And then the spleen on the patient's left and the liver on the patient's right. And so that's really kind of maximally invasive surgery, but really that's the way we've traditionally operated on patients who require surgery for gastric cancer. Next slide, please. So this is laparoscopic surgery, and I did use some iStock Getty images, so you'll notice that all over the image on the right. But basically what we do is we map out how we're gonna put these incisions on the patient's abdomen, and we use that image to the left just shows kind of the breastbone at the very top of the image and kind of the creases of where the thighs start on the bottom of the image. And that's where we put the incisions, one near the belly button and 2 up to the left and 2 up to the right. And then we make small incisions, we look inside, we look around, we safely place the remainder of the incisions. And then as you can see from the image to the right, that the patients are standing the surgeons are standing to the patient's bedside on either side with an assistant, and basically using long instruments that are doing the operation on the inside, but the surgeon is controlling it from the outside. So this is excellent in terms of keeping everything through small incisions and try to provide the same outcomes as we would with an open operation. Next slide, please. And I would say in the last roughly 10 years or so, there has been a push towards robotic surgery in some ways or another. So robotic surgery is basically the same concept as laparoscopic surgery, where you're making these small incisions. And however, as you look at the setup on the left, the surgeon initially helps the assistant place the robotic arms into the patient's abdomen. The assistant is there to help switch out the instruments. And in the same room, the surgeon is sitting at a console, kind of as that very middle image would indicate. The surgeon sits there and uses their hands to actually finally move the instruments on the robot inside of the patient. So unfortunately, we haven't gotten to the point where we can operate from home yet. And I believe that that's probably never going to happen. But the point is, we're not letting the robot do the operation. We're usually augmenting our own surgical skills through small incisions and through the arms of the robot to do the operation safely. And again, if there's any issues, the surgeon is in the room just a couple feet away and can quickly scrub in and help, convert to an open operation as needed. Next slide, please. So this is just the image so you saw the surgeon's head inside of this console, and this is the image that the surgeon is seeing from inside of their console, and that the supporting ancillary staff and the assistant are seeing from the cameras in the room, or sorry, the screens from the room. They are actually piloting this almost like a virtual headpiece that the assistants can put on to look around and actually see the same view that the surgeon sees from the console. And so this is just the stomach being divided here with the stapler. Next slide, please. Next slide, please. Oh, thank you. So how do we decide whether to do something with an open operation, a laparoscopic operation, or a robotic operation? And this is really determined on a case-by-case basis. If something is really advanced, even if you have surgeon experience or comfort with both those other techniques, most surgeons will decide to do that operation with an open incision to do it safely and get the best surgical outcome and the best cancer outcome we can. So again, it's also reliant upon surgeon experience and comfort. And we talk about early and locally advanced gastric cancer. So locally advanced means it's bigger in that area, but it's all confined to that area. Those can actually be considered safely for a minimally invasive technique or an MIS technique. And again, minimally invasive surgery is using the long instruments laparoscopically or using the robot through the console robotically. And there are studies to show that the outcomes are same, both from the short-term surgery outcome as well as from the long-term cancer outcome standpoint in the East and the West. And the reason it's important that they're equivalent both on the East and the West is those are two different patient populations. I'm not talking the Eastern US and the Western US, I'm talking about Asia versus the United States. And Dr. In will get into that a little bit more with her presentation. Minimally invasive approaches are generally not recommended for, that's just T4B or N2 means big, bulky gastric cancers, again, from a safety standpoint and from getting the same surgical oncologic outcome as we would, or cancer outcome as we would with an open technique. Next slide, please. So is one technique safer than the other? And I'm not going to bore you with statistics or with too many papers, but I do want to kind of just show that this has been covered and has actually been studied. So these 4 studies listed on the very last line are studies that were basically conducted as trials to show that laparoscopic surgery is not inferior to open surgery. So these are specific studies to show that they can be conducted safely. These same operations can be conducted safely using a laparoscopic technique as an open technique. So these studies will look at the morbidity, which basically means, does someone have an infection? Do they have a bleeding issue? Any complication after surgery, as well as mortality, looking at the death rate after an operation, and then looking at the long-term cancer outcomes. And these studies some of them looked at subtotal gastrectomy, which means, again, only taking out part of the stomach, and looked at taking out the entire stomach. And then also a very important part of this operation is taking out the associated lymph nodes, which is called a lymphadenectomy. And some of these studies looked at early cancers versus, again, more advanced cancers. And so the first 2 studies that listed in the line below were conducted in China, and the last 2 were conducted with Korean patients. But again, there are studies throughout the US showing that laparoscopic surgery is as safe as open surgery for gastric cancer. Next slide, please. I will bore you a little bit with a study or 2 here. This is to show that robotic surgery, so those studies that were published looking at non-inferiority studies between laparoscopic and open surgery were actually just published in 2019 and 2020, so just recently, really. And these studies were both published this one was published in May of 2021, and the next one was in October of 2021. And in this study, roughly 300 patients were randomized to either robotic surgery or laparoscopic surgery. And what they found was that basically the robotic groups tended to have they had a faster postoperative recovery, milder inflammatory response, and decreased risk of complications robotically than laparoscopically. And we found that the lymph node harvest, or getting more lymph nodes, was a little bit better with the robotic group. And also that surgeons were more likely to get those lymph nodes with the robotic group than the laparoscopic group. Next slide, please. They were also more likely to make it onto chemotherapy after surgery, which is really important from a cancer standpoint. But robotic surgery can be very costly, and each surgical intervention robotically, which was much more costly than laparoscopic surgery, with the direct cost overall for the robotic group being lower than the laparoscopic group. And my thoughts with that would be, maybe if there's less complications, we're spending less money, hospital dollars, on those patients done robotically overall. Next slide, please. So this study is another study, about 250 patients, which showed that their primary endpoint, so the thing that they were actually looking for was infection in the abdomen after surgery. And in terms of postoperative complications for intra-abdominal infection, there really was no difference in the 2 groups. And there was a little bit higher risk of complications of the laparoscopic group than robotic group. Now, with all of that being said, you can kind of find data to support either side depending on where you look. And these were just the 2 most recent studies that came out that really randomized patients. And what that means is, basically at the time of prior to undergoing a surgical intervention, they either decide you're going to get a robotic surgery, you're going to get a laparoscopic surgery. So it's really just very random how they do the assignments. And those were the only 2 randomized studies I found between robotic surgery and laparoscopic surgery. But I think there's still a lot more to be studied here to really figure out if one is safer than the other. Next slide, please. Next slide, please. So again, which surgical technique is better? Next slide, please. It really comes down to 2 major things. And one is surgical preference and experience. I should say 3. The second thing is the patient's tumor and what's appropriate to undergo which kind of operation. And then the third thing is the availability of the resources at the institution. So it may be that an institution doesn't have a robot, and that's not an option, but those surgeons may be very well skilled in laparoscopic surgery, or in other institutions they may not have. You may have an extremely skilled surgeon who's an open surgeon who doesn't do things laparoscopically or robotically. And I think ultimately, the patients are looking for really just a safe surgeon who's going to give them the best cancer outcomes. Next slide, please. So when you look at the three of us on the session here today, Dr. August primarily does an open technique, Dr. In does primarily laparoscopic technique, and I myself primarily do a robotic technique. And I would say we all have we all have good outcomes, and I think the technique is less important than the comfort level of the surgeon with whatever technique they're approaching for these cancer operations. Next slide, please. So from a surgeon perspective, I would say that the open surgery is the foundation of all surgical intervention. Unless you know how to do the surgery open, I think it's really difficult to do the surgery laparoscopically or robotically. So the foundation of all surgical intervention is really open surgery. And open surgery should really be utilized for large locally advanced tumors and for patients also who are medically ill, because sometimes laparoscopic surgery and robotic surgery may take a little bit longer. So on someone who is medically frail, you know, in an effort to get them on and off the operating room table and to minimize anesthesia, I do think an open technique is the best. Laparoscopic surgery requires a different skill set to be utilized by those who are comfortable and trained with these skills. And I trained mostly in an era of robotic surgery, and I know Dr. In is very comfortable laparoscopically, and so she has a skill set that I actually don't have. And robotic surgery in some way is actually an augmentation of a surgeon's open skills, but does require a significant amount of training. But at the end of the day, for me, it's ergonomically better for a surgeon because I'm sitting down and operating as opposed to hunched over a patient. So I hope in 20 years, I'm going to be grateful that it saves my back from having further injury in the future. Next slide, please. From a patient perspective, you know, I think the majority of patients, when they come into my clinic, most of them don't ask me, how are you going to do this operation? And if they do ask, I would say the majority of them are really just want to know. And I would say maybe 5% of them are really interested in, if you're not going to do it robotically, then I'd rather have it done with someone else. And the point of that being, I think most patients who have cancer really just want a good, safe, oncologically sound operation, which is going to give them the best cancer outcome. The size of the incision may or may not be important to the patient. It's really just patient perspective and patient preference. And the goal of any operation is get patients onto the chemotherapy they require after surgery, because we know by delaying their chemotherapy, we're actually, you know, potentially delaying their cancer treatment, obviously. And the goal of any operation is cure gastric cancer and cure the diagnosis of stomach cancer. The one thing that may be a little bit beneficial, I think, in terms of what approach you use is the smaller your wound, the decreased risk of wound infection, and the quicker you may make it onto chemotherapy after surgery. With that being said, I think gastric cancer in general, the stomach contents are less likely to create a wound infection than, for instance, a colon cancer or a colon operation because of the bugs that grow out of the stomach. Next slide, please. Next slide, please. So in conclusion, there are three main surgical techniques for gastric cancer. One is open surgery, the other is laparoscopic surgery, and the third is robotic surgery. We have proven that laparoscopic surgery is not inferior to open surgery, but we definitely need more data to validate this on robotic techniques. And ultimately, surgical technique is based on the tumor itself, on patient factors, and on surgeon comfort and experience. And thank you for your time.
Great, Dr. Grandi. Very nice presentation. Thank you very much. Yeah, I've had the opportunity to train in an era when things like laparoscopic surgery and robotic surgery weren't even a dream. And in the early 90s, when they began to come into abdominal surgery, particularly the laparoscopic surgery, those of us who trained earlier started out making fun of them, that it was crazy to do things that way when we had a better way to do it. And over the past 30 years, it's really been developed in a way that that makes open, laparoscopic, and robotic surgery all very appropriate choices in the right situations. So again, thank you very much for that great presentation.
Thank you.
Our next presenter is Dr. Patrick Boland. Dr. Boland is a medical oncology member of our multidisciplinary gastric cancer team here at the Cancer Institute of New Jersey, the Rutgers Cancer Institute of New Jersey. And Patrick joined us, I think, about 2.5 years ago. Is that right? And again, has been a welcomed addition to the group. His patients really like him and respect him, and his input into our decision making for multidisciplinary care of gastric cancer patients is really invaluable. Dr. Boland graduated from Jefferson Medical College, which is now the Sidney Kimmel Medical College, went on to Boston University to do his residency, and then did his medical oncology training at Fox Chase. After Fox Chase, he went up to Roswell Park Cancer Institute in Buffalo, spent a few years there, and as I said, joined us about 2.5 years ago. A very important addition to the armamentarium for gastric cancer treatment has been immunotherapy as an adjunct, an alternative, a supplement at times to gastric cancer chemotherapy. And Dr. Boland will be speaking today about immunotherapy for gastric cancer at the frontier, and this is truly state-of-the-art care. So, Patrick, thank you.
Great, thanks for the introduction. And it's definitely my pleasure to be here talking about this. So I'm just gonna give a little update on sort of where we are, what's changed recently, and just talk about a tiny bit on what's coming, but very tiny actually. So next slide. This is my disclosures. Next slide. So yeah, so just sort of for starters, we don't need to dive too much into the details of this, but just to point out, not all, so I'm going to talk a little bit about gastric and esophageal, just because there is a continuum, but not all stomach cancers are the same, right? And so there was this, the TCGA was this collaborative effort to really understand what's the genomics, what's the makeup of gastric cancers, and really there they subcategorized tumors into 1 of 4 groups, and there's a bit of a continuum as you go through the different parts of the stomach, and we don't have to dive too deep, but basically think of the 2 most common are the purple and the greens. This is like they call it like CIN. This is the most common sort of stomach cancer. Looks kind of like the intestines under the microscope. There's also probably next most common is this diffuse histology. That is a little bit of a different beast. And then the other 2 really, I think they're predominantly of relevance because these are the ones that are most responsive to immunotherapies. The other, the intestinal type and the genomically stable certainly can be as well, but especially the 2 on the right. Next slide. And so if you just sort of backing up a little bit, so, working our way down from the upper part of the upper reaches of the esophagus to the small intestine, so, through the stomach. As I said, there's a continuum. So in the esophagus, we predominantly have if you look at the microscope, they're squamous cells, so we call them squamous cell cancers until you get down to the lower stretches of the esophagus, and then the cells start to look more like what you see in the stomach. And so when you get to this area of the junction, the GE junction, so between the esophagus and the stomach, for the most part, the tumors tend to be more like stomach cancers, just sort of differentiating how we treat things somewhat. And when we look, we look at this. Well, it's nice to know the genomics, and I think there will be some more future applicability for many of these things. At least right now, what do we use in practice? How do we, make determinations? So I think in early stage, this doesn't altogether change things, but I think the main biomarker that really that we look at is MSI. And then when somebody has metastatic disease or just significantly advanced disease, it's definitely a must to know MSI, this HER2, the PD-L1 score, and potentially EBV. Although EBV is quite uncommon in the West here. Next slide. So since we're talking about immunotherapy, just sort of going to bring out there are multiple different types of cells that make up the immune microenvironment. So we often talk about T cells, thinking about these CD8 T cells, these ones really being the effectors, the ones who are doing the work. But there's a whole mix, and some of the cells are good, anti-tumor, and some of them are potentially bad, potentially might be getting in the way of our treatments working and worsening the prognosis. And clearly there's links for some of these things to long-term outcome, regardless of treatment. Next slide. So in the, there's a whole process by which the immune system is regulated. So there's signals to sort of dampen things, to quiet things down, and there's signals to activate things. And so predominantly when we talk about immunotherapy, right now anyways, for cancers and particularly for gastric cancer, what we think of is these immune checkpoints. And so the drugs we have are basically drugs that block these block signaling between these immune checkpoints. And so really the one of most relevance is PD-L1, which interacts with PD-1. And these are present both on tumor cells as well as immune cells in the environment. And basically when there's binding of the two and there's this interaction that you can see on this diagram, it essentially quiets down the effector cells. It quiets down the immune cells that would otherwise fight against the cancer. And so it causes this thing, it's often referred to as immune exhaustion. And so there's a whole bunch of drugs that target this interaction, either by hitting the PD-1 side or the PD-L1 side. And the ones really that are of relevance here are these antibodies, these proteins. And so nivolumab and pembrolizumab are two of the many. And these are drugs that are currently utilized in the clinics. Next slide. And so just one more thing sort of about markers. So, the way that we really assess, right now, beyond sort of the MSI for these immune checkpoint inhibitors is this PD-L1 score. And so what this is essentially staining of the tumor for this PD-L1 protein. And so initially we had this thing TPS where we really just scored the tumor cells were positive, but and sometimes we still do see that reported out. But what we really care about is what's called the PD-L1 CPS score. So it's a combination of both the tumor and the immune staining. So you can see this is the bottom left picture where you have more cells that are lit up. Because certainly some tumors do not have PD-L1, but the immune cells around them can have robust PD-L1 expression, and that's potentially still actionable. Next slide. So I'm just gonna, as I give just a brief sort of summary of all this, just gonna talk about some of the studies, and gonna start sort of in the metastatic space, because that's sort of the proving ground for a lot of treatments traditionally. So this is really the pivotal study that looked at giving the PD-1 drug nivolumab, which is Opdivo, that was reported out in the last 2 years. And so basically this study, so patients who had metastatic adenocarcinomas, predominantly of the stomach, but also of that GE junction, and a small portion with the esophagus were from the study. They were mostly patients who had adenocarcinomas, and they were negative for that HER2 marker. And basically what the study did is folks got the standard chemotherapy, or they had the chemotherapy with nivolumab added. And we looked at kind of some of the standard outcomes. How did people do? Next slide. And what we saw here, so this is, I'll talk about what this says, but basically we saw that the response improved when we added nivolumab, so it improved by about 15%. And patients who responded had significantly longer lasting responses, with some of them very long lasting. And that's a fault of some of the chemotherapies, is the responses don't last long enough. And actually this translated to survival being improved. So these curves here, we don't need to talk too much about them, but these are basically, this is a curve, the y-axis, the vertical axis is survival, and the horizontal x-axis is really the months. So you can see we still have a lot of work to do but clearly this treatment is shifting the curve up. So patients are living longer when we add these drugs, and we see the effect really is biggest in the group that's PD-L1 positive, specifically a score more than 5, or at least 5. Next slide. So not to belabor it, but basically they did a whole bunch of breakdown to look at, okay, is there what's the best cutoff? There was, this is kind of decided before and during the study, and really what we see is that tumors where the PD-L1 score is less than 5, they're quite unlikely to get any significant benefit from adding nivolumab. And so, based on this data, kind of more than what I'm just showing you here, and other things that we've seen in other studies and knowledge really from the NCCN guidelines, the recommendation is that tumors that have a PD-L1 score of at least 5, that nivolumab be considered, unless there's some other reason that patients are at risk for getting this drug. And whether or not patients get a benefit, if we give them the drug, they still have the same risk of side effects. So, patients with low scores, really, I don't think, it's not worth the while for them. Next slide. And so basically this is something some very smart statisticians did, where they basically pulled some of the data from these studies. And what they looked at here is, this is a curve looking at survival of patients with lower PD-L1 scores with nivolumab versus without. You can see really they're totally overlapping. There's no difference. And so again, nivolumab is approved actually for everybody with metastatic disease. And we're not going to go too much into that. But really, expert opinion as it stands today would be PD-L1 CPS score of at least 5 is really where you're getting your bang. And in Europe, that's actually the only place where it's approved. They tend to be a little bit more conservative there. Next slide. That same study, just to mention this anyways, because I'm gonna talk about something else briefly later. But I sort of had a grayed out arm. So there was on that study some patients who didn't get chemo at all. So it was a chemo-free combination immunotherapy regimen. And so it was giving the 2 major immune checkpoints that are in the clinics, the 2 major drugs that 2 major classes of drugs anyways, that block immune checkpoints that are in the clinics. And this was actually closed early, unfortunately. So it didn't kind of fully enroll, didn't complete. But essentially the combination immunotherapy was no better than chemotherapy. And when you look at it some other ways, it would be more clear than the curves that I'm showing you. But I would just note, when we look at the survival curves, you can see that there is actually some portion of patients who aren't getting chemo at all, who are getting this combination immunotherapy, who actually seem to have reasonably good outcomes. Or at least it seems to be that there's a higher proportion that have longer lasting survival than with chemotherapy alone. Now, how much the ipilimumab, the Yervoy is adding, is kind of less clear here, but you suspect it's adding something. But because of sort of the, all the details involved here, this is really not a recommended option. Chemotherapy is on average of more benefit for patients. Next slide. Great. And so just one other thing to touch on, this is the last thing about metastatic disease, this is also very recent, really in the last year. So this study, we actually don't know, we don't have sort of the full results from yet, but we saw highly encouraging results that were reported in Nature. So it's about 20%, plus or minus, of patients that have HER2 positive tumors. So this is just one of these biomarkers. And the standard there really is to give chemotherapy plus this targeted drug, Herceptin or trastuzumab. And so what this study did is they looked at adding, a PD-1 inhibitor to that combination versus just giving the combination. And we saw that it really boosted the response rate. We saw that about 11% of patients had complete responses on the scans, which certainly is better than the standard. And you can see this on the right. Here's a waterfall plot. So all the bars are individual patients, and you can see the percentage change. So pretty much everybody had a decrease. Just about. There's a couple people who didn't, unfortunately. So this was actually approved. We're awaiting sort of the full results of this, but this is the standard of care today for patients with HER2 positive tumors that are advanced. Next slide. So just sort of summary of metastatic disease. So nivolumab clearly improves outcomes when we add it to chemotherapy in the advanced stages, and this is mostly in the PD-L1 positive CPS5, and that, you know, as I said, so typically FOLFOX or CAPOX with nivolumab is what we advise if the biomarkers are right. Folks who have HER2 positive disease, when we add the pembrolizumab Keytruda to the standard therapy, it absolutely improves tumor shrinkage, and we're hoping it improves long-term outcomes. I expect it will. We just don't actually have that data yet. So it is a standard of care in HER2 positive tumors. There is a little bit of data out there with some other drugs still showing high activity even without the chemo. That's not a standard today, but certainly there's interest in that sort of approach when folks can't tolerate the full chemotherapy. But again, not the standard. And in terms of like combination immune checkpoints, it's still under heavy investigation. It's not advised at this time. You know, the role, I mean, I said unclear. It's actually clear that should not be given as a first therapy. But it's possible, as I pointed out, that tail where there's a portion of patients who are getting long-term control, it's possible that most may still have a role in earlier stage disease. Next slide. So just as we talk a couple slides about early stage disease, I'm just showing this again. So this is just a true cartoon of not a fun cartoon, but so basically this is just showing the esophagus, the junction, and the stomach, and these areas that are colored in all represent the GE junction. So we tend to, in early stage disease, decide our treatments based upon where the tumor is located, with a distinction, you know, around the GE junction. The areas in the purple, blue, and above, we tend to treat more often like esophagus cancer, whereas those that are, you know, kind of green and below, we tend to treat more like stomach cancer. You know, I think there can be a little bit of a debate with the purple ones which way we go, but that's, you know, I think that's generally the accepted practice in the United States, and I think that's ours. Next slide. So for early stage esophageal cancer, so this is just, you know, sort of the medical oncology perspective, really for the most part, you know, with at least stage 1B disease, we tend to advise chemoradiation before surgery. And then because of some data I'll show you, really the standard is to give immunotherapy for a year afterwards if they have residual tumor left. And the most common regimen utilized is this carboplatin and paclitaxel, or we call it sometimes carbotaxol. There is some evidence for FOLFOX. There are places that will give FOLFOX, and I think that's actually a reasonable alternative. And the operative immunotherapy here is nivolumab. And really the goal of all this is to maximize chances of cure. And I think, you know, when we think about how we're doing things, you know, limit risk of complications, you know, maximize successful surgery. Next slide. And so for stomach cancer, you know, for gastric cancer, it tends to be similar. You know, I think we can debate some of the early stage, you know, the early end of this a little bit, but somewhere around stage 1B, we tend to gravitate towards giving chemotherapy before and after surgery. So really the standard is to give approximately 2 months before surgery and 2 months after surgery. Because the data I'm not going to show here, really the most effective is this combination of 3 drugs called FLOT, though oftentimes we give FOLFOX or sort of similar versions of that. You know, depending on a discussion with the patients and looking at what's gonna sit best with them, what's not gonna put them at too much risk of bad complications, because in the end of the day, you know, surgery is the major thing, and I don't want to do anything that gets in the way of that. Next slide. So keeping this in mind, so when we think about esophageal cancer, where we give, you know, radiation and chemotherapy as a standard, this is this nivolumab study. So basically what this study did, checkmate 577, so patients with esophagus cancer and cancer of the junction here, essentially who had chemoradiation and then had tumor left, you know, in the surgery sample, there was still some tumor cells left there. They got randomized either to get Opdivo, so nivolumab, for a year, or just to be watched, which would be really the standard before this study. And you know, 3/4 of these patients had adenocarcinomas. These were like I said, it was largely lower esophageal and GE junction, but some uppers. Next slide. And what they saw really is when we added nivolumab, outcomes were better. We don't have all the data on this yet, but we look at the rate of recurrence, of development of metastases. At least on this initial readout, it was about 10% absolute improvement. You know, the relative improvement's much bigger than that, and we saw that the median was better too. But what you can see is on this curve of looking at patients who are alive and haven't recurred, you know, there's a clear improvement. It really kind of shifts things up. And when they looked across all the different subgroups, like, you know, where did it start, how old were they, what was their sex, the benefit was consistent across all of them. Next slide. And when you look at, so what's the cost of this? What are the side effects? So this is just sort of the most common side effects that we're seeing, or that were reported with nivolumab versus the placebo. So there is a rate of side effects, but what you can see is that it's actually, for most of these, it's not that different between the drug and placebo. You know, certainly all these things I've showed you are a little bit higher, except maybe diarrhea. You know, tiredness is about 6% higher. Itching and rash we can definitely get. They're not that common, and they're usually pretty mild and easy to treat. Underactive and overactive thyroid are usually also not a big deal, and are well addressed. But for the most part, we see kind of mild or no side effects with this, although there's a small proportion of patients that can have bigger issues. We've got to watch closely. Next slide. So really, for cancers of the junction here, you know, they're getting radiation up front, and for the esophagus, the standard now really is, you know, we look at, did they have tumor in the surgical sample that was still viable, that was still there, and if they did, you know, which is 3/4 of patients, then we steer towards nivolumab, Opdivo. If they did not, the standard now really is just to watch them as we've always done. I think what we don't know is we don't necessarily have all the data on what's the survival impact. I have to think, I would be very surprised if there's not a significant survival benefit from this. We just don't have the follow-up yet to know that. We don't know what does PD-L1 score mean actually here. There's suggestion that it probably matters, but we really just don't truly know that yet. At this point, I'm not prepared to you know, to advise a patient not to get it based on the PD-L1 score. And then on the other hand, if patients have like a GE junction tumor and get preoperative chemotherapy instead of radiation, what's the role of Opdivo? We actually just don't have any data for that. It's certainly something I think you would rationalize it. It would probably help, but we don't know is the probably the most conservative answer I can give you on that one. And so really what we still need to do is we need to figure out how can we improve further on this? How can we, you know, how can we cure more people? How do we make this better? And I think some of the things are, you know, certainly, you know, bringing novel agents in, I think, is one of our hopes. You know, better biomarkers, I think better understanding PD-L1 and sort of other sorts of ways of understanding immunotherapy responsiveness. And then, you know, the last few years have seen really a huge increase in interest in use of ctDNA. Could this be used to pick out patients, honestly, who have residual disease but don't need Opdivo? You know, maybe. I think we're not there right now, but those are certainly potential futures. Next slide. So sorry, this is really small and hard to read. So this is an ongoing study that we have open here. It's open across the United States. So this is a National Cancer Institute supported phase 2/3 study. And basically this study is looking at two things. So it's for patients, this is really esophagus and gastroesophageal junction tumors. It's not really gastric. But so patients are treated with the standard chemo radiation, so chemotherapy plus radiation, and they get randomized to get Opdivo or not. So, you know, to see is there an extra benefit in terms of, you know, tumor shrinking with adding Opdivo with radiation. And then after surgery, actually patients are then randomized to either get nivolumab, you know, which would be standard, like I said, or to have nivolumab and ipilimumab, so Yervoy. So that's a combination where I was suggesting it's not better than chemo alone, but there seems to be this tail where there's, you know, where there's a subset of patients who are getting a good additional benefit. So this is one potential way we may be able to build upon the, you know, the post-operative nivolumab. This is ongoing. It's going to be a few years till we have any results, at least. Next slide. This is, another study here. And so this study really is looking at what's the role of giving a PD-1 inhibitor with resectable stomach cancer, right? So the question I brought up, what if you get chemotherapy pre-op? Or for these, these type 2 GE junction ones, should we prefer to give chemoradiation instead of chemo because of the Opdivo? I don't think we know that. But so basically, this is a Merck-funded study, and there's some others too. But this one is done enrolling, as I understand it, and hopefully in not too long we have results, but it will still be a little bit. But basically, what this study is looking at is for patients with stomach cancer, it's looking at if we add Keytruda pre and post therapy, do we improve outcomes? And most of the patients are getting a regimen like sort of like FOLFOX on this, but it's made to be a worldwide study, which is why the drugs aren't exactly the same. A small portion of them are getting flat. So there's still going to be some questions remaining after we have this. Next slide. And this is, I'll just point out, this is just one other study that we have ongoing here. So this is Dr. Jabor's study and Dr. Kennedy. So this is a study looking at, so in patients who have resectable stomach cancer, really there's two questions. It's what's the role of giving Keytruda again, and then what's the interaction with radiation? Does it work better when we give it with the radiation post-operatively? So this study is for patients with gastric cancer who are PD-L1 positive or have those immune markers I pointed out, MSI or EBV positive, and they get a brief course of pembrolizumab before surgery, and then we add pembrolizumab on during the after surgery course, which includes getting a little bit of oral chemotherapy as well as radiation. Next slide. So just gonna sort of shift gears a little bit. So I just want to talk about this because this is fairly brand new data. So I mean, MSI high gastric cancer. So this is a small portion. So most of the time when somebody's diagnosed, they're not going to have this, but it's something to look for. Some of these are related to this hereditary condition, Lynch syndrome. And what's unique about these tumors is that there's basically a defect in repairing some of the errors that happen when cells divide. So you can get high accumulation of mutations. So they have high mutational rates, and that probably results in targets for the immune system to see. So they tend to have more immune cells around the tumor. And what we know, at least in some of these, from some early studies, so this a study that was published a couple years ago, 2020, that when we give a PD-1 inhibitor to MSI high gastric cancer in the metastatic setting, actually the response is quite, is quite good by our standards, right? So it's about 60% compared to only about 40% with chemotherapy. When we combine the two, it's even a little bit higher. Now these numbers are really high. We're talking about I'm saying this based on less than 60 patients. This is not many because it's a fairly uncommon finding. Next slide. And so again, here is just sort of looking at this, these curves. What we see actually in the metastatic setting, very small numbers is the issue, is that when we give immunotherapy as compared to chemotherapy for MSI high tumors, the outcomes seem to be better actually. And these are, both responses and then sort of these survival curves here. And it's unclear if you give the combination, is it better than single agent? We really don't know that. Next slide. On the other hand, when we look at early stage stomach cancers that have this MSI high feature, their prognosis is actually better on the whole. So this is again these Kaplan-Meier curves, so survival versus time. And what's important here is that the blue curve is better than the red curve, right? So that's the MSI high patients. So they do better kind of regardless of what happens. Next slide. That's specific to early stage setting. And so this was from 3 years ago, I guess 2019. This is a pooled analysis of four kind of seminal studies in early stage gastric cancer. And so MSI high patients were about a little under 8%. And they looked at outcome if they got surgery alone versus chemotherapy. And they looked at, the MSI high patients and the ones who weren't MSI high, and we call them, MSS. And what you can see here, or what this is supposed to demonstrate, don't need to go in the weeds, is that basically there didn't really seem to be a big improvement. If anything, it trends toward maybe a little bit worse with giving MSI high patients chemotherapy, pre and post surgery. Whereas, clearly we can see a difference in the patients who are not MSI high. So, again, sort of suggesting that, these patients do better. The upper two curves are the MSI high patients, and that probably they don't get a great bang from chemotherapy. Next slide. So this was presented at our GI oncology meeting in January, and so this is a study that basically looked at, for MSI high stomach cancers, giving them combination immunotherapy for 3 months before surgery, and they gave them Opdivo or nivolumab after surgery. Next slide. And so I think remarkably what they saw was that at the time of surgery, after 3 months of immunotherapy, really about 60% of patients didn't have any tumor left. And if you look at the remainder, there's another almost 15% where there were just barely any tumor cells left. So, really, I think quite remarkable. Certainly when we give chemo alone for, for the run of the mill, or when we give, chemo radiation, we don't expect anything near that. Next slide. And this here is, this is very early. This is very early data. There's not this isn't enough patients to make definitive conclusions. We don't have enough kind of follow-up, but these are curves looking at, how many patients are without a recurrence and are they alive or not. And you can see these curves are hugging the very top of the graph here, unlike the other ones I showed you. So these patients all did extremely well afterwards. They had one patient where they had progression during those 3 months, but otherwise, all of them really did, the remainder really did very, very well. Next slide. So, I think this is early data, very small numbers, but highly encouraging. We have some data that MSI high gastric cancers are resistant to chemotherapy. Clearly, the immunotherapy drugs are highly active for MSI high tumors in metastatic disease, but we now also have some data in early stage resectable tumors. What's the uncertainty now? What are the limitations? So this, the study that I showed you really was with combination therapy. There's a couple other reports out there with kind of single, just giving pembrolizumab or just giving nivolumab. So how much is enough if we're to pursue that? We don't know yet. Giving one drug alone may be enough. I suspect there's a small extra benefit to giving the second drug, but we really don't definitively know. And then, if those patients get that sort of therapy, where do all of our standards, fall in? So these are uncertain things. This is not a standard right now here today. We don't have long-term outcomes. These are all very small numbers, but I think this is highly, highly intriguing. And certainly there is work to get some, some studies that will give us more definitive answers, but it's going to take, global cooperation, because these are small subsets of patients. Next slide. So I think that is everything for me. So thank you.
Great. Thank you very much, Patrick. This is, some of these data are hot off the press, and new ways of treating even advanced gastric cancer. We've been at this for an hour. I'm going to suggest that, standing in place, that we take about a 1.5 minute stretch break. So I'm going to stand up and stretch, and we'll wait about a minute here, just give people a chance to do that, and then we'll get started with our next speaker, Dr. In. About another minute, so stretch quickly. Okay, there we go. Dr. N is back. Excellent. So our next speaker is Dr. Haejin In. Dr. In is the newest member of our multidisciplinary gastric cancer team. She arrived about 7-8 months ago, I think, and very distinguished background. She holds faculty positions both in medical oncology here at the Rutgers Cancer Institute in New Jersey, but also in Department of Health, Behavior, Society, and Policy at the Rutgers School of Public Health. She obtained her medical degree in South Korea, trained at Boston Medical Center, received a surgical oncology training, her cancer surgery training out at the University of Chicago. Along the way, she also picked up a couple of master's degrees at Harvard, one in public health and the other in business administration. And she serves in a variety of positions nationally related to gastric cancer and the care of gastric cancer patients. Dr. In also holds the title of here at the Rutgers Cancer Institute in New Jersey as our Associate Director of Diversity, Equity, and Inclusion. And that's going to be the topic of her talk today. She'll fill us in on the fact that there are great disparities in healthcare delivery according to race, socioeconomic status, and the like. And it's an important focus of research moving forward, how to deal with those disparities and get better care to everybody in this country. So Dr. In will speak about healthcare disparities and equity in gastric cancer. You're on.
Great. Thank you so much for this. Thank you for this opportunity to speak. So, you know, as I was introduced, I am a surgeon, so a surgical oncologist who specializes in stomach cancer. But as a researcher, I'm a public health researcher trying to work on how we can minimize disparities for gastric cancer and improve outcomes for gastric cancer in a public health manner, so in a population setting. Next slide. Next slide. So when we're talking about cancer disparities, one of the ways you can ask this question is, are certain people in the population at greater risk for dying from gastric cancer? And unfortunately, in the United States, the answer is unequivocally yes. Next slide. In the most recent American Association for Cancer Research Disparities Report, this was just published in 2020, they found that among all the cancers, gastric cancer has one of the highest rates of disparity in cancer-related death. This is for African Americans, for Hispanics, and for Asian Pacific Islanders compared to whites. Next slide. And this mortality difference is great. They were twice as likely to die from stomach cancer. So we have a big disparity that we need to figure out. Next slide. So as I said, I'm putting on my public health hat on, and so I'm not really going to go into you know, genetic causes of cancer and such. I'm going to keep it at a population level. And as I'm addressing this, I want to first frame it as, well, why are then some populations at greater risk from stomach cancer? Next slide. So when we're thinking about stomach cancer, or gastric cancer as we like to call it as well, we have to remember that stomach cancer actually is quite a common cancer around the world. Stomach cancer is the 5th most common cancer after breast cancer, lung cancer, colorectal cancer, and prostate cancer. and there's more than 1 million new cases diagnosed worldwide. In terms of death, it's the 4th leading cause of cancer death worldwide after lung cancer, colorectal, and liver cancer. So as you can see, gastric cancer around the world is extremely common and extremely lethal. Next slide. However, in the United States, we talk a bit less about stomach cancer, and it's not as much in the we don't think about it as much. And one of the reasons for this is that it's not as common across the board in the United States. So this is a heat map of incidence rate in all across the world. And you can see that, America depicted in light blue, you can see that the rates are not as high as other countries in the world. You can see that in many parts of Asia, Europe, and South and Central America, there's a very high prevalence. Next slide. And so countries such as Mongolia, Korea, Japan, China, you can see that the rates of gastric cancer are nearly tenfold. So if the United States diagnoses for every 100,000 persons, their rates are nearly 10 times that of the United States. Next slide. This is also true for Russia and its surrounding countries, including countries such as Latvia, Belarus, Turkey, Iran, and many of the STAN countries. Next slide. And Central America as well. Central America and South America as well. Costa Rica, Colombia, Peru, Chile, all have extremely high rates of gastric cancer. Next slide. So when we put this all together, next slide, and we think about America being a melting pot where all of these people from all of these countries are coming into the United States, we can think about the fact that there might be some differences because people don't lose their risk when they come to the United States. Next slide. Now let's focus on what America itself looks like. So for whites, gastric cancer is not, as I said, a top 10 cancer. But because the majority of the population is white, when we think about, in a population level, the risk kind of gets washed out. And because of that, gastric cancer doesn't seem to be a very high risk cancer. But if you look within the racial and ethnic subsets, so for Blacks, Asians, and Hispanics, gastric cancer is actually a top 10 cancer. And among Koreans, Japanese, Chinese, Vietnamese, it's a top 5 cancer for those ethnicities. Next slide. And here I'm just pointing out how different the incidence rates are. So if for the white population, the incidence rate is 5.8, you can see that for the Black population, it's double that at 10.3. Next slide. For the Hispanic population as well, there's differences, but for Mexicans and Puerto Ricans, it's once again extremely high, nearly double the rate. Next slide. And for Asians as well, there is heterogeneity, but for certain populations, there's nearly a 4- to 5-fold difference. Next slide. And the burden of cancer is great in these ethnic populations. So this is a study of Asians, and you can see that Asians only make 9% of the total population. However, they burden 16% of all of gastric cancer. Next slide. So putting all of this together, how do we think about this? And how do we think about, the fact that all around the world, there's extremely high rates? Next slide. And when they come over, next slide. And so this is a study that shows the difference between, and how immigration plays into this. So there's large differences in incidence depending on immigration generation, where you can see that native Chinese, so these are people who lived in China who are first generation immigrants compared to Chinese Americans. So that's indicating people who were born here of Chinese descent. You can see that there's a huge difference in incidence rate. Next slide. This is the same for Koreans as well as and compared to Korean Americans. Next slide. And native Japanese compared to Japanese American. Next slide. And so putting all these studies together, you could see that first generation immigrants had similar risk as their home country, but by the second generation, their risk starts to go down. However, even for future generation, the risk never quite becomes as low as the general population US. Next slide. So as we think about, how to tackle mortality and how do we improve upon mortality from gastric cancer, next slide. I have to take a step back and talk about first, well, then why do we get gastric cancer? What is the etiology of this? And one of the main factors is Helicobacter pylori infection. Next slide. So Helicobacter pylori is a bacterial infection that colonizes in the stomach mucosa. And it triggers a series of inflammatory reactions that lead to gastric cancer. Studies have now shown, and this is relatively new, back in the day, we didn't realize that Helicobacter pylori played such a large role. We knew it played a role, but not this large a role. But more recent studies are showing that 89% of gastric cancer is associated with Helicobacter pylori, meaning that most of the gastric cancers we see are actually related to Helicobacter pylori. And the WHO has now classified Helicobacter pylori as a class 1 carcinogen. If you look at this cascade of how Helicobacter pylori, triggers this, you can see that we start off with normal gastric cancer mucosa that gets infected with Helicobacter pylori. In general, people get infected before the age of 5. So it's a bacterial infection that you get very, very early. We don't really quite know how it gets transmitted. We think that there might be something, oral to oral that seems to come in families. So there is some transmission. We don't exactly know the root why. Once you get infected with Helicobacter pylori, the mucosa of the stomach starts to undergo changes. First, an inflammatory response that we call gastritis. Then the mucosa starts to wither away in a way, called atrophic gastritis. Then the cells really start to change, called intestinal metaplasia. Further changes called dysplasia, and then ultimately gastric cancer. Next slide. There are other risk factors for gastric cancer, such as we know that having high intake of salt, red meat, processed foods, and pickled foods are bad. Fruits and vegetables do seem to be protective. Once again, as I pointed out, Helicobacter pylori infection confers a 3 times risk for gastric cancer or more. Family history of gastric cancer, being male, and smoking and alcohol also increases your chances of gastric cancer. Next slide. And because of this, when we start thinking about how do we prevent it, well, first off, just like any other cancer, living a healthier lifestyle is better. So limiting foods that are salt preserved, such as smoked or pickled foods, not smoking, drinking just minimally. Here I wrote less than 3 drinks, but really less than 1 drink a day is preferred, and increasing your food intake. Next slide. But specifically for gastric cancer, the big thing is, from a prevention standpoint, is treating the Helicobacter pylori infection. So, because it makes so much sense, if you think about it, that we treat Helicobacter pylori infection as a way to control gastric cancer, there have been 6 very large randomized control trials, mostly out of Asia, that have tested a test and treat strategy where they test to see if a person has it, and if the person has it, they will go ahead and treat it. Now, treatment for Helicobacter pylori is actually relatively straightforward. It's antibiotics. And those studies showed that treatment of active Helicobacter pylori reduces the incidence of gastric cancer by 35 to 50%. So it makes a lot of sense. The test for Helicobacter pylori is relatively straightforward. You can do either a breath test, you can send in a stool sample, or you can get an endoscopy. Next slide. And to decrease mortality from gastric cancer, the other strategy would be to find the cancers either when they can be prevented or when you can find them in a treatable state. So an upper endoscopy, or what we call an EGD, can look for the Helicobacter pylori, and it can also look for cancer as well as precursor lesions, so early lesions that can be removed, similar to how you think about a polypectomy when you're thinking about colon and colon cancer. Next slide. And we know that endoscopy for screening really does work. And this is a study, or this is a report out of Japan, which shows that 5-year survival that's happening in the United States versus Japan after they started screening is markedly different. So in this figure here, you can see my red arrow where after they initiated screening, this is in Japan in the 1960s, their rates of gastric cancer death plummeted substantially. And now 5-year survival for Japan is around 60%, while in the United States, we're still only in the 30%. This is already a report from nearly 20 years ago. If you look at reports now, Japanese 5-year survival is close to 70%, which is such a stark difference than what we see in the United States. And the biggest difference seems to be this, where you can see here in this figure that Japan diagnoses most of their cancers in a localized stage where cure is very possible, while as in the United States, most cancers are being diagnosed in a metastatic stage where cure is pretty much not, really feasible. Next slide. So then one might ask, so why aren't we then screening for gastric cancer? Doesn't it just make a lot of sense? Well, it does. But then there are some issues. So this is the National Cancer Institute's webpage where I took this off of. And this really shows what they're thinking. They conclude that there's inadequate evidence of benefit associated with screening, but evidence from East Asia is consistent with substantial reduction in gastric cancer mortality. However, studies in high-risk regions, so all of the studies that are coming out of Asia, may not be applicable to low-risk regions such as the United States. So what they're saying is that, yeah, it looks like it works in, those countries that have a lot of gastric cancer, but hey, in the United States, we don't see a lot of it, so maybe it's not applicable. But now I've shown you the disparities. You know that in certain populations that they're actually high risk. So shouldn't we have something for them? Next slide. The National Cancer Institute does point out this, though. They do have clinical considerations for high-risk groups, saying that there may be justification for screening some populations of Americans with higher risk. And they go on to point out some groups, but still say that there needs to be some discussion about how risky it needs to be. Next slide. Societies also know this. So this is the guideline from the American Society for Gastrointestinal Endoscopy, where they have guidelines that suggest that screening EGD for gastric cancer in new immigrants from high-risk regions around the world, such as Korea, Japan, China, Russia, South America, especially if there's a family history of gastric cancer in a first-degree relative, is endorsed. However, we know that such recommendations, unless they're endorsed and written into policy by federal agencies such as the National Cancer Institute or Medicare, really will not, you can't get insurance companies to pay for these until these are written out like that. And so we still have a lot of work to do. Next slide. So myself and other researchers who are interested in improving gastric cancer outcomes in the United States continue to investigate how to develop a prevention and screening strategy that's applicable to the United States population. Here at CINJ, myself and my team, we're getting ready to launch our latest research, which is to explore whether doing a gastric cancer screening at the same time you're getting your colon cancer screening would be feasible and possible. So if you look at this schema, a person who's getting scheduled for their screening colonoscopy, and we would screen them to see if they're a high-risk person for gastric cancer. So if they're a racial ethnic minority, if they're a first generation from a high-risk country, or if they have family history of gastric cancer. and we would ask them to enroll in our study, which adds on a upper endoscopy. And we expect that a strategy of doing an upper endoscopy like this simultaneously with a colonoscopy will be very effective and efficient. And we hope that this really would be a strategy that can reduce gastric cancer for high-risk populations. Next slide. So in summary, yes, large racial and ethnic disparities exist for gastric cancer mortality, and prevention and screening greatly does improve mortality for gastric cancer and should be recommended in individuals at high risk. But we do desperately need policies to establish such prevention and screening programs for high-risk populations to reduce the burden of gastric cancer. Thank you.
Great, Dr. N. Thank you very much. Very, very informative. Our final speaker is Ms. Kristen Waldron. Kristen is a registered dietitian who is board certified as a specialist in oncology nutrition working here at the Rutgers Cancer Institute in New Jersey. And she's a clinical instructor in the Department of Nutritional Sciences at the Rutgers School of Health-Related Professions. Kristen and I have worked together for, I think, more than a decade now, and we've written some things together. Just a pleasure to work with, and just a valuable member of our team in working with our patient population to help them deal with some of the side effects of gastric cancer and the side effects of the treatment of gastric cancer. So Kristen will speak with us today about diet and gastric cancer. Eat to live, live to eat. Take it away.
Thank you, Dr. August. I appreciate it. And I just want to thank Debbie's Dream Foundation for having me here. And I learned so much from my colleagues and their presentations, so thank you to them as well. So I am a dietitian at Rutgers, and I'm going to be presenting about, like Dr. August said, diet and gastric cancer. Since I've been here, and yes, it has been a decade, Dr. August, I have been, a big group of mine has been the GI tumor board group. So I have a lot of experience with GI cancers, including gastric cancer. Next slide. So I think before we dive into nutrition, I just thought it would be important to, kind of list the cancer-related treatment and post-surgical symptoms that you can experience at any time during your cancer journey. Some of these symptoms you may even have prior to your diagnosis. So I think it's important just to kind of list these. Some of them, these are not all of them. These are really just the ones that affect your nutrition intake. And I'm sure I even missed a few as I was listing them, but these are some of the primarily big symptoms that we kind of come across that patients will complain about. Taste changes, smell affecting taste of food, mouth sores, so difficulty swallowing can be present. Sometimes people, depending on where their tumor lies, if it's more closer to that junction between the esophagus and the stomach, like closer to the top of your stomach, the proximal stomach, some people actually feel that, when they swallow their food or when they're eating, it almost kind of gets stuck, like it can't fully go down. So you can even have a difficulty of like a difficulty swallowing, so to speak. Heartburn and indigestion, sometimes these can be present prior to the diagnosis, but with heartburn, this can actually get worse during treatment as well. So it's important to kind of keep that in mind. I did want to touch upon nausea and vomiting. I do know at Rutgers Cancer Institute, this is something that we always tell our patients that these are symptoms and side effects that we can completely control. A lot of my patients will be prescribed an anti-nausea medicine, and we come to find out that they're not taking it correctly. And what I mean by correctly is they're not taking it to help prevent the nausea. They're actually taking it in reaction to. So you might have a better handle on the nausea if you're taking it as a preventative measure. So that's something to kind of keep in mind and make sure you discuss with your healthcare team. You know, I don't want you to ever think, oh, I feel nauseous, I can't eat. You know, a lot of people feel defeated if they're undergoing that. So it's important to make sure that you talk with your doctors, talk with a dietitian, see what you can do to combat this. I do know just from the cancer diagnosis, the stomach cancer diagnosis, and then from treatments, and then even after surgery, if you have a gastrectomy, that nausea is something that people tend to battle with a lot. So, you know, if you're on one particular medicine and that's not working for you, there's a lot of other different medications. There's cocktails of medications that, you know, different combinations, so to speak, that doctors can put you on to help control the nausea. And what some people do, one of the biggest mistakes I think that people make is when they feel nauseous, they don't eat. And that can actually make the nausea feel worse. So you want to make sure that, you know, I'll get a little bit into it when as the presentation goes on, but we want you to eat small amounts of food frequently throughout the day. That might have a better handle on it. So it's not even eating every 2 hours. I mean, if nausea is something that you're really battling with, you may have to eat just a bite or two of food every half hour, 45 minutes, every hour or so, just to make sure that you're feeding the gastric juices in your stomach that are still waiting for food. So another symptom that people struggle with, early satiety or feeling full. You know, some people too, even before they're diagnosed, they feel fine, and they'll actually just have the complaint that, you know, I feel okay, but I think I'm eating less. You know, I'm taking in less during my meals, and you know, I used to have a snack or two during the day, not really feeling hungry for that. So they'll just have the, you know, the complaint of feeling full. And obviously this is something that can happen when you're getting treatment and then after a gastrectomy as well if you do have surgery. Loss of appetite, bowel issues, meaning diarrhea, constipation, feeling bloated, having excess gas. These are all things that we want to get a handle on, especially the bowel movement issues. You know, some people tend to struggle with constipation. It can happen sometimes with treatment, but this could happen more so after surgery, especially if you're on pain medicine. So it's important to let us know if you're constipated. And then diarrhea can happen from treatment. It could happen depending on your eating patterns after surgery. And diarrhea can be a little bit dangerous because if you have diarrhea, especially frequently throughout the day, frequent bouts of diarrhea, you're going to lose nutrients, you're going to lose fluid when you have those bowel movements. So it's really important that we try to get that under control. And then fatigue. Fatigue is a symptom that people don't really associate with from like a nutrition symptom and side effect. I mean, a lot of the times it's cancer fatigue that people are feeling, but if you're feeling tired, you're not eating well, you're not getting the energy your body needs. And if you're feeling tired, you may be napping frequently throughout the day. And if you're napping, you're losing time to eat. So I threw fatigue in there as well as a symptom that can affect your nutrition intake. Next slide. So getting into eating a balanced diet, you know, we have kind of, and how I explained it to patients, we kind of have this hub of calories. Calorie composition is important while you're on treatment. If you're prepping your body for surgery, healing from surgery. So it's important that you're getting the right calories in your body. You want to keep in mind that if you're on treatment and if you're healing from surgery, your calorie needs and your protein needs are actually higher than what they should be. Your body is utilizing more energy, more calories, more protein to heal itself. So you might feel lousy, you might feel crummy, you might be battling some of the symptoms that were on the previous slide. However, we do need you to be taking in food, and probably more so than before you were diagnosed with cancer. So under this calorie composition, we have your three major macronutrients: protein, fat, and carbohydrates. Protein I'll discuss a little bit more in more detail on the next slide, but just to kind of note that what the importance of protein. It's needed for digestion, it's needed for the growth and repair of your muscles and other tissues in your body, and it helps keep your immune system healthy. As far as fat goes, fat is very calorically dense, so grams of fat will add up quickly from a caloric standpoint compared to protein and carbohydrates. That doesn't make it more important. It's just important that it's just important to keep in mind, if you can tolerate fatty foods, healthier fatty foods, like the unsaturated fatty foods, that you want to try to incorporate those in your diet. Monounsaturated, polyunsaturated fat sources usually come from oils, olive oil, canola oil, peanut oils, flaxseed oil, avocados, nuts, and seeds. So you can get healthy calories into your body from a fat source. Obviously saturated fat is in some animal proteins, especially the red meats are a little bit higher in saturated fat. Doesn't mean that you can't have it. It's just we don't want it to be a primary source of nutrition in your diet. But you have your saturated fats, also coconut oil and palm oil all do have some saturated fat in it as well. And then there's the trans fats. The trans fats are kind of like the no-no fats, the fats that we want you to avoid. But all in all, like I said, I mean, fat is just important to help you to get the calories that you need. Not saying go crazy on the trans fats, but if there is a food or two that does have some source of trans fats, you want to try to limit it or avoid it as much as possible. But during the time of healing, we want you to get your calories in. It would be okay if this is in your diet. As far as carbohydrates go, it's important to keep in mind that you do not want to completely ban or restrict carbohydrates from your diet. I can't tell you how many times I've had patients tell me, when I go up to them, well, how's everything going with eating? What are you doing from, a diet perspective? And they'll say, well, I've decided to cut out sugar from my diet, or I know sugar feeds cancer, so I'm not, I'm avoiding extra sugar, and I'm only having 2 servings of carbs a day. That's not really the way to do it. You do not want to restrict carbohydrates from your diet. Our brains alone just live on glucose and sugar alone. So you want to make sure that you're getting plenty of carbohydrates, healthy carbohydrates in your diet. Some people will then say, oh, well, when I go for a scan and I get injected with the glucose, I know sugar feeds cancer because my cancer lights up on the scans, when I take the glucose in. So cancer cells, as well as other sources of inflammation in the body, they're more metabolically active. So they are going to the glucose is going to gravitate and get metabolized by those cells faster. So I wish it were as simple as saying, listen, avoid sugar in your diet and you'll be good to go. But it's not that simple. I think if that were the case, we would all be shouting it from the rooftops. But it is important to make sure that carbohydrates are part of your diet. With that being said, there are different components of having carbohydrates in your diet. You have the simple sugars or the simple carbs, which mostly come from the white refined sugar, the cakes, the cookies, ice cream, things like that. You also want to make sure that, from a complex carbohydrate standpoint, that those are the whole grains, beans, lentils, legumes, things like that. And those are the sources in your diet. Moving ahead down to water, to staying hydrated.
Kristen, are you still there?
She may have froze. We'll give it a few seconds.
That look on her face, it looks like she just saw a tiger or something,
Yes. Let's see.
Brittany, if you'll take over here, I'll call her on her cell phone, okay? I'll be right back with you, okay?
No worries. Thank you so much. Thank you everyone for your patience. As we know, sometimes technology can get the best of us. And this is one of those moments. If you'll just please stand by, we greatly appreciate it.
Just bear with me a minute. I'm ringing her cell phone.
It looks like she just joined us again. Hold on.
Hi, Kristen indeed had a computer problem. I must
Okay.
say I have not seen her slides before, but I will begin to go through them with you. So if we could move on to the next slide, please. So why do you need protein? The scaffolding of your body is really protein. Your muscles and the repair of all the tissues in your body is dependent upon the presence of muscles. Furthermore, some of the main chemicals in the body are enzymes that control all of metabolism, and those are proteins. So proteins are a crucial part of what we eat, particularly in people who are ill, particularly in people who have lost weight, who have gotten weaker. Protein is really a key to rehabilitation and building back up. And it looks like
Dr. August,
Kristen
I'm
is
back.
there, and I will let her take over.
I am so sorry about that, ladies and gentlemen. I was enjoying the presentations before so much and I didn't realize how low my battery was. I apologize. But thank you for covering for me, Dr. August. So yes, going on to protein. It is a very important part in any part of where you're at in your cancer journey. So during treatment, we want to keep that muscle mass on. It's going to help keep your weight stable. After surgery, it's certainly going to help you with healing. So what are some sources of those protein-rich foods? So you have animal sources, red meat, and under that category of red meat, you have beef, lamb, pork, goat, that kind of under that hub, chicken, turkey, fish, eggs, dairy products. With that being said, you want to try to limit your red meat intake to maybe about 2 servings a week. Listen, if that's something that works for you, it's okay. If it happens to be a little bit more than that, especially if you're healing and you're getting that, you need that protein. But the red meat actually contains more heme than the other animal products that are listed. Heme can also be an irritant. So whether you're undergoing treatment and you still have your stomach, if you go under for a gastrectomy and you come out with a small remnant of your stomach, or if you have a total gastrectomy, getting the whole stomach removed, it can irritate your system and irritate your space. So you want to try to limit that intake to about maybe 2 servings a week. If you're able to, I don't want you to choose fat-free dairy products. If you can tolerate the extra fat, low fat at least, if not full fat dairy products, I would want you to take those in for the source of extra calories that they have. Whole fat dairy products also have more omega-3 fatty acids, which are those unsaturated fatty acids. Our bodies can't actually produce those on their own, and they have some anti-inflammatory properties. So if you can tolerate the full fat, at least the low fat, but if you can tolerate the full fat dairy products, I would want you to take those in as well. Plant sources of protein. You have nuts and nut butters, legumes, and under that category of legumes, kind of everything in parentheses, just kind of pretend that they're cousins. Peanuts and peanut butter, beans, peas, lentils, soybeans are all under that category of legumes. Seeds, quinoa are all important sources of protein. So obviously, depending on what kind of symptoms and side effects you're having, wherever you are in your cancer journey, some foods may be harder for you to tolerate at certain times, depending on what kind of symptoms you're having. But whatever you're able to take in from a protein standpoint, it is important that you try to meet your protein needs. Next slide. Okay, so kind of going back to the title, Eat to Live with Gastric Cancer. So, eating unfortunately may not be something that is enjoyable. It's going to seem something more like a chore. Some people, I kind of refer to it as like a full-time job. You need to make sure that you're eating. Sometimes it helps people to think of their food as medicine. You want to make sure that you don't miss a dose. You go to your cancer center for treatment on certain days of the week. You take medicines at home at certain times of the day. You want to treat food the same way. So you want to treat it as like a medicine, something that needs to be taken in. Sometimes it helps when people set meal and snack timers throughout the day. So this way, if a timer goes off maybe every hour and a half or 2 hours, no matter what you're doing or how you're feeling, that timer goes off, okay, I need to eat something. And it doesn't need to be a 5-course meal. It could be something as simple, maybe like 3 or 4 cracker rounds with some peanut butter spread on them. It could be a small cup of yogurt, even if it's a half a cup of yogurt, or a couple ounces of cottage cheese, a hard-boiled egg, something simple like that to get some protein in, to give you some energy. Eating on a schedule can also help with people. Some people kind of have the same daily routine that they go through day in and day out. So they know that they wake up early, maybe they need to take some medicines on an empty stomach, and then they'll start breakfast around 7:30, and they kind of take off from there. Every 2.5 hours, have a meal, have a snack, have a meal, so on and so forth. So sometimes eating on a schedule can be helpful as well. And then drinking your calories, especially if you're having a hard time taking in those calories from solid food. A lot of people, whether it's certain stages of treatment, whether it's certain days or weeks after surgery, they're just not really feeling solid foods, and that's okay, as long as you're getting your calories through some point, through some source. Commercial supplements, Boost, Ensure, Carbonation Instant Breakfast, there's Muscle Milk, Premier Protein. There's a bunch of different nutrition supplements that are commercially available. People like the convenience of them, that they can just keep in the refrigerator, they can kind of take out, and they can, sip on them throughout the day. If you do have any kind of GI cancer, especially gastric cancer, you might not be able to tolerate the whole supplement at once. So what I recommend patients do is to kind of sip on it throughout the day. Or even if you have a small breakfast, maybe take a sip or two of some kind of nutrition drink or a supplement, put it back in the fridge, take it out after your snack, have a few more sips. And this way it can help ensure that, those are supplemental calories to try to get into your diet if you're able to take in solid foods. Obviously, if you're not able to, and that's the main source of your calories, sipping on them throughout the day will definitely be beneficial for you. Sometimes commercial products aren't for everyone, so you can make your own shakes and smoothies, have a family member or a friend make them for you. What I would suggest is definitely making them in the morning, so this way you have it in the morning and can sip on it throughout the day. Next slide. So for those of you in preparation for a gastrectomy or have had a gastrectomy, I just wanted to kind of list some of those post-gastrectomy diet tips that may be helpful for you. This is more so in the sense immediately following your surgery. However, as you go through that post-surgical recuperation phase and recovery phase, you may realize that some of these tips you need to stick with longer, and they're just helpful for you in the long term. So consuming small frequent meals and snacks throughout the day, grazing throughout the day, picking a little bit here, picking a little bit there. Taking small bites, chewing food really well can definitely help with just tolerating food in general. Eating slowly in a relaxed atmosphere, limiting fluid consumption during meals. And the reason we say this is we don't want you to feel full when you're taking in the liquids. So, if you're drinking a lot of liquids, say 8, 10, 12, 16 ounces of liquids, that can make you feel full, and then you're only able to take a few bites of food. So we say maybe 4 ounces at most that you're drinking. This way, if you need to wet your whistle, you might need a sip of water or some kind of fluid just to kind of help the food go down. That's perfectly fine, but don't overdo it. You want to make sure that you stop to eat when you do feel full, when satiety is reached. If you are having issues with gas and bloating, you want to try to avoid carbonated beverages and drinking through straws. Some people drinking through straws works, and I have a guest speaker that will probably hit on that in a few minutes. But carbonated beverages, just the carbonation, the gas bubbles from them, will definitely make you feel full on their own. So that's something that you probably want to avoid for a little while after surgery. You want to try to sit upright and remain upright for about 45 to 60 minutes. Just kind of think that gravity needs to be on your side. You're going to help work the food down into your system. You want to make sure that it's kind of going where it needs to go. If you lay down right away, some people will regurgitate, or they'll get really bad reflux or that feeling of reflux. So you want to make sure that you try to sit upright while you're eating. And then try to avoid eating short to bed, about 2 hours or so close to bedtime. And then limiting simple sugars. And you want to monitor for dumping syndrome. So those simple sugars that I mentioned before in the previous slide, when we're talking about calories, these foods you may not be able to tolerate all that much after surgery. Over time, your system, your space, your GI tract will get used to it. But these are foods that probably won't work for you. So to also help prevent dumping syndrome, you want to try to avoid these foods. And you want to try to stay active. Staying active just kind of helps keep your muscle mass on. You will lose a lot of muscle mass after surgery, so we want to try to replenish that as much as possible. And it can also help with your appetite and digestion. Next slide. Next slide.
Next slide, please.
Well, I can certainly start talking about it before it comes up, but we are on the next slide, Brittany, whenever you get a chance. So I just wanted to touch a little bit more about dumping syndrome. Thank you. So dumping syndrome can happen more so if you have a total gastrectomy. I do have some people, depending on how much of the stomach is left over, that they may struggle with this if they have a subtotal or partial gastrectomy, but it usually happens with the total gastrectomy patients. Early dumping syndrome versus late dumping syndrome. So early dumping syndrome can happen pretty soon after you eat. It can probably even happen within 15 minutes or a half an hour after you eat, but it can go up to an hour or so afterwards. So this is when the small intestine fills too quickly with undigested food. What happens is water is pulled into the intestines to try to flush it out. So with that, you will have symptoms like you can feel nauseous, you can vomit. A big one that we have for patients is they have diarrhea, they'll have gas, they'll have bloating, they'll feel lightheaded. So this is early dumping syndrome. And it doesn't go to say that everyone struggles with this. I think if you eat correctly, and I'll get to that on the next slide, if you take precautions on trying to prevent this, let's say it happens to you one time, I think it's likely that it can be controlled. And then late dumping syndrome, I don't see too often. It's usually early dumping syndrome that I work with patients with. But late dumping syndrome happens about 1 to 3 hours after they eat. And what happens is when sugar is absorbed too quickly into the bloodstream. So what happens is your glucose levels rise very, very quickly, and then they kind of plummet quickly. And you go into a state of what we call hypoglycemia, or you have low blood sugar. And these symptoms include fatigue, weakness, dizziness. You may all of a sudden feel really hungry. You'll have a rapid heart rate. You'll get sweaty. So these are the symptoms of late dumping syndrome. Next slide. Next slide. So thank you. And so some tips if you can just go back to the dumping syndrome. So tips to prevent dumping syndrome. A lot of them are similar to the post-gastrectomy diet tips, like eating small frequent meals throughout the day. You want to limit your simple sugars. You do want to make sure that you have protein with every meal and every snack. Sometimes it can help to incorporate higher fiber and complex carbohydrates into your diet. The higher fiber foods can actually slow down the transit time of food. So if you are struggling a little bit with that early dumping syndrome, the fiber can kind of slow down the contents of how quickly it moves through your system. Taking small bites of food and chewing well is something that you want to also keep in mind. Not drinking a large amount of liquids. So sometimes fatty foods can also cause dumping syndrome. So if fatty foods are giving you an issue, you may want to try to limit those as much as possible. And then this is actually something that's reversed from the post-gastrectomy diet. So if you are struggling with especially the early dumping syndrome, where things are just kind of moving through too quickly, you actually might want to lie down a little bit, or maybe a little bit on an angle for about 15 minutes, even up to a half an hour. Like I said, just kind of thinking about gravity. If gravity is going to work on your side and you're experiencing dumping syndrome, laying down a little bit to slow down the movement may be helpful for you. Next slide. So I did list some resources. Obviously, I didn't list Debbie's Dream Foundation because I'm sure you're all familiar with it, but they have great nutrition resources, recipes, cooking demos on there. But a lot of people will ask me, well, do you have recipes? I'm having a hard time menu planning, especially if you're having symptom-related issues and you're not sure what foods to eat. These are some wonderful resources that not only give you recipes, but other nutrition tips that you can help follow, that can help you as well throughout your journey. So I would like to leave this slide up while I introduce my guest speaker. He is a patient of Rutgers Cancer Institute. He started his journey about 4 years ago, and his name is Michael Del Priora. Mike, are you on with us?
We can't hear you there, Mike.
How about now?
Yes.
Excellent.
You can't hear me? Okay,
you,
now
Mike.
I'm get my head up there. Let's see if I can do
Sure.
that.
But thank you so much for being here, Mike. We're very grateful that you're here and willing to talk about your journey. So for the people that are on the line, he's kind of been there and done that. He's had some struggles along the way, but we're happy to have him here just to discuss a little bit about what he went through. So Mike, can you just kind of tell us a little bit about your journey in a nutshell as far as when things started for you and what you went through?
Okay, I apologize. I can't get my picture up there, but I don't want to lose you. I'm a patient of Dr. Kennedy's, an associate of Dr. August, and I want to thank from Dr. August right down to the whole team. You've been fantastic. 4 years ago, on March 22nd, I was diagnosed with stomach cancer, and if you name whatever complications there were, I had it. I'm a diabetic, so I was a work in progress for Kristen because I went from not eating carbs and being on a special diet to now I'm, the diabetes is in check. I'm no longer on insulin. And I've been working with Kristen over the years. And initially I had a problem swallowing. I don't know if it was a psychological thing, but Kristen and I worked it out. During chemo treatment, I mean, I don't have to tell anybody who's doing it. Nothing tastes good. Everything tastes, the water's like metal. I would get to the point where I would chew my food and I went to swallow. I couldn't swallow it. I would spit it out. But all these things we worked through. As I said, it's 4 years. My weight's been maintained now for the last 2. And I feel great. I'm back to doing energy levels there. I'm doing everything I did in the past. I'm 50 pounds lighter, but it's a good thing. It's a good thing. So I don't know what else to say, just to thank everybody very much. And, and the nutrition was a big part of it, a very big part of it. I can take protein in moderation. I could, any commercial drinks, I can't have because it just gives me gas. But I do the eggs, 3 eggs a day. If I have 4, I have nothing. I have problems. And I eat a lot of nuts, so that's where I've been getting my protein. That's all I got to say. I mean, but you guys have been fantastic. Kristen has been there anytime I need her. And thank you, and I appreciate you inviting me to be on this webcam. Yeah.
Well, thank you for being
Thank
here,
you.
Mike. What would you say, what was your biggest struggle? Was it during treatment? Was it after surgery? Where would you say some of your biggest struggles were?
Well, I'll be honest with you. I struggled all along the way. I'm a pharmacist, and you learn in school about these drugs and what they do and their side effects, and you really don't realize it until you go through it. okay, and you know, you don't realize, you know, you can't drink cold on certain drugs, and you know, the taste, you can't, nothing tastes the same. And going right through, you know, the surgery, actually, probably the surgery to me, maybe because I was under, you know, that went okay, but I ended up getting an infection, and, you know, back and forth to the hospital. And, but the eating, on my second round of chemo treatment, the third treatment, I ended up, you know, I was down to 132 pounds. You know, Dr. Malhotra had sent, you know, nutrition to the house, and I just couldn't eat. I just couldn't eat, and I didn't want to eat, you know. And then, you know, we worked through that, and, you know, and chewing. And like you said, you got to chew your food. I thought I could have a little piece of steak, and if you didn't chew it 50 times, it didn't go down. You know, like I said, I would just spit it out. So, and swallowing, believe it or not, the straw helped a lot. Because I don't know, when I was drinking the water, I don't know if I was taking in air and I was getting like gas pockets, but when like this straw made like everything smooth. You know, I would drink it slow, and, you know, and that all got me through it. It did get me through it. You know, and then as far as eating, I don't have an appetite. I forget to eat. I'll be honest with you, I do forget to eat. I mean, I could go a day or two without eating and not even think about it, you know, which is not good. I mean, I realize that, but, you know, I usually get through it. Smarties helps. Really, you know, I don't know. Thanks. Thank you for everything.
No, of course. And that's, I mean, that's where it goes to show that it's individualized. So, I mean, something like straws worked for you, where other people, it might incorporate more gas for them. So, you know, that's where we kind of have to play around with things and see what works for you. And I think for a while, Mike, you were in that eat to live mode that you needed to really survive. And, you know, I mean, even now, I mean, you should be reminding yourself to eat, but
Yeah.
we can work on that behind the scenes. But no, it's, you know, I just seeing you and your journey, you've definitely come a long way. And again, I just want to thank you for being here, and being available. I know when we have our Q&A, if anyone wants to ask you questions, we appreciate it immensely.
Okay,
So
thanks for inviting me. I really appreciate it. Thank you. Thanks.
Of course.
Great. Thank you both very, very much. You know, I'll just very quickly pick up on something that Michael said. He talked about working with Kristen. And I think that that's the general message that I would try to leave with everybody on this webinar, that we as care providers really need you to work with us. It has to be a partnership. We need the feedback from you. We need to hear the good and the bad. And only if we really know through you what's going on and can share that with you, can we then try to help you. You know, this is a team sport, and I think Michael encapsulated that nicely. I'd like to thank Kristen and Michael and Dr. In, Dr. Grandi, Dr. Boland for joining us today. We do have time for some questions. Looking at it, I know that Dr. In is available. I think Dr. Grandi is in the operating room, and Dr. Boland is seeing patients over in clinic. But between Kristen, Dr. In, and I, we'll try to deal with questions that come up.
Perfect. Thank you all so much. All the presentations were awesome, and I'm really glad on behalf of Debbie's Dream Foundation that we could have you all present today. It looks like we did get some questions, and Dr. August, you can let me know. Would you want me to read them out loud, or do you want me to type them in the chat box? Either way.
Why don't you read them out loud?
Okay, perfect. So Susan asks, when evaluating a surgeon who operates robotically, is there a number of surgeries at which the surgeon would be considered very experienced? Is it 50 to 100?
Dr. In, you want to take a swing at that?
Yeah, Dr. August, it's Muriel Grandi. I'm on as well.
Ah,
Was
okay,
was this
great.
was this for the robotic experience?
Yes.
Yes.
So sorry, I don't have my camera on, but that's a great question. And I think when it comes to robotic surgery, you know, I know what the threshold is for pancreatectomy. I'm not sure what the threshold is for gastric cancer, and I don't know if that has been fully measured. All of these cases at some point do have a threshold where you have a minimum number of cases where you start to feel comfortable on the robot. But again, I don't know what the specific number is for gastrectomies. I think a lot of things in surgery are translatable. So if you're doing robotic distal pancreatectomies, that may be we're taking out the tail of the pancreas. That's very translatable to robotic gastrectomy. But I would have to say, if I had to guess, it would probably be roughly 30 or so. Dr. In, any thoughts on that?
So yes, I agree. You know, it's a certain technique that we're using, and so you know, maybe it doesn't necessarily have to be the same surgery over and over again, but if the surgeon is comfortable with the technology, then the procedure is translatable, and then you want to make sure that the surgeon also has experience with the gastric cancer surgery as well. So it'll be a combination of the two. And then in terms of a pure number, you know, some people are quick learners, some people are not. You know, we too are humans, and so you do have to take that into account. But there's also certain quality metrics that you're going to be looking for when you're dealing with gastric cancer quality, you know, the quality of the surgery. And one of the big ones is lymph node dissections. So does the surgeon endorse lymph node dissection that's done as endorsed by all of the society guidelines, which is a D2 dissection, which means, you know, cleaning off all of the vasculature that has the lymph nodes surrounding the stomach, and cleaning that out as well. So I think that those are good questions to ask when you're trying to find a surgeon to work with.
Awesome, thank you. Next, we have a question from Christian. Christian says she had a CRS HIPEC surgery in January of last year. Since then, she has been suffering from CIPN at Johns Hopkins Hospital. What is the treatment for this type of neuropathy? Does Keytruda treatment contribute to CIPN? Oh, she had a correction. Her surgery was at Johns Hopkins. The CIPN occurred after FLOT, I think she said. After FLOT treatment and surgery.
Yeah, so I'm sorry that Dr. Boland had to leave. He'd really be the expert on this. In general, the neuropathy that we see after treatments like FLOT relate to the oxaliplatin, one of the drugs in that regimen. And it is duration dependent, meaning that the longer you're on the oxaliplatin, the more of it you get, the more likely it is to develop that neuropathy. And it's unusual to have a severe neuropathy under 6 months. It can be, you know, fairly manageable at that point. That almost everybody, when they get out to 12 months, can have real problems with that neuropathy. It tends to be worse in extremes of weather, particularly cold weather. So keeping warm, using hand warmers, good gloves can be helpful. Paying attention to when you're eating, holding a cup full of cold liquid versus room temperature liquid. There are some drugs that can help with that, things like gabapentin, Neurontin, that can make the neuropathy more tolerable. There really is no cure for it, and it really just has to be managed.
Okay, thank you very much. The next question is, most presentations, this is from Corey Peck, by the way, most presentations I've seen from oncologists regarding immunotherapy always seem to discuss HER2 positive and MS high, PDH1/5 positive, as these are the markers that have been proven to correlate well with these new drugs, Yet no one discusses patients that are negative for these specific markers and don't qualify for any immunotherapy. What are they to do, and what is being worked on development-wise for these types?
Dr. N, I saw you nodding. Do you want to take a try with that?
Sure, I'll take a try at it. I unfortunately, I'm not a medical oncologist, so I am a surgeon. So I can't speak to this direct, with a lot of information, but I do know that it is, when there's no markers to go after, the fallback does become the traditional chemotherapy. I do know that some immunotherapies right now that are that are currently FDA approved actually don't have a PD-L1 level specific to it, even though we know that, for example, PD-L1 CPS score greater than 5 is better. At the same time, we also, FDA has approved it generally. So it is a tough situation. I am not going to be able to comment on what new investigational drugs there are for people who don't have those markers, unfortunately.
So I can add to that a little bit that, this alphabet soup, PD-L1, MSI, HER2/neu, it's really representative of a big advance in cancer care in general, and I think particularly in gastric cancer care, so-called personalized medicine, where we can now look at specific markers on a tumor, specific aspects biochemically of the tumor, and use those to direct therapy. And that's what all of these things are about. Unfortunately, there are some tumors that at this time we're just not smart enough to know what those personalized targets should be. I know that here, oftentimes when there are no targets, there are no markers that can be used to direct the therapy, and standard chemotherapy has failed, that we often, on the basis of FDA recommendations, do try immunotherapy, knowing that it's less likely to be helpful. And it's really through studies and further research that we're going to get more markers, more targets, so that some people aren't left out in the cold without having targets for therapy.
Thank you so much. It looks like we have another question for Dr. Boland, but maybe someone can answer. What is on the horizon for those patients that are HER2 positive or MSI high or PD-L positive? Is there any other options being researched?
I can't speak to what's next. There are new immunotherapy drugs being developed and tried, and particularly for MSI high tumors, these are tumors that already seem to stimulate the immune system somewhat, so that the drugs that we give get rid of things that are blocking that immune response and help it work. And there's certainly work on different and newer immunotherapy drugs. I'm not really aware of what some of the other approaches are.
Okay, thank you so much. Sarah asked, will this recording be available by Debbie Stream? Absolutely, it will be. You can check back sometime early next week. It should be on our lecture library on our website at debbiestream.org. Next question. My husband has completed 16 rounds of chemo and immunotherapy for stage 4 adenocarcinoma. Scans are stable after significant reduction in disease. I'm researching HIPEC and surgery if we can get it back on the table. Any thoughts on this? And this is from Sarah.
Dr. N?
So, the standard of care would be no, but however, we know that there are always certain situations where things can be considered. And it will very much depend on how well the cancer has responded to the therapy that he's gotten. So it will depend, but I would say if he's had a good response, it is worth discussion.
Thank you. Another question is from Sanjita. Do you think B12 injection is necessary even if you have normal level of reading in your blood report?
So the stomach creates a protein called intrinsic factor that allows the body to absorb vitamin B12. And without a stomach, you don't have intrinsic factor and can't absorb vitamin B12. And that's why some people after gastric cancer therapy require vitamin B12 supplementation. There are inhaled versions of that that kind of sniff. One of the issues with those, they tend to be pretty expensive, and vitamin B12 shots are actually fairly inexpensive. It turns out it's just easier, cheaper, and for most people more convenient to just get B12 shots on a regular basis if they've lost most of their stomach, or if the stomach has been irradiated so it doesn't make adequate intrinsic factor. But if you have normal B12 levels, there's no reason in particular to take supplemental B12. But if you're in the situation where you don't have a lot of stomach or it's been irradiated, it's important to check those levels on a regular basis.
Thank you. Victor asked, what does it mean if the current chemo treatment for gastric cancer is no longer working? Has the cancer mutated? Should the tumor be resampled to determine the markers in order to determine best immunotherapy treatment?
So the nature, all cancer is genetic. That doesn't mean that it's inherited, but all cancers occur because there are abnormalities in genes that lead to uncontrolled cell growth and the ability to invade, to metastasize, to avoid the immune system. And those genetic changes continue to occur throughout the lifetime of the cancer, throughout the lifetime of the patient, so that as we administer treatments and kill off the cells that are susceptible to those treatments, there are often other cells, cancer cells, that have picked up the ability to avoid being killed off by those treatments. And that's why eventually most of these systemic treatments stop working. And when they stop working, it's important to see if there are other potential treatments, if there are other investigational agents that can be tried. But ultimately, this is why some cancers aren't curable, because they evade all of the therapies that we have.
Okay, thank you so much. We have another question from Brona. Brona says, regarding other targets, my son is on a clinical trial targeting the claudin 18.2 protein. He doesn't have these other biomarkers like HER2, etc. This is helping him. There does appear to be new research on some proteins, but studies are still in early phase 1. I'm not sure if that's a question. She's saying the trial is out of MGH, Boston, and other locations if anyone wants more info. That's just, she's sharing. Thank you so much, Brona. And I think there was one other question. Oh, for Kristen, this was a comment from Melanie. She said that Kristen needs her own webinar. Thank you for all of the information. And it looks like
I agree.
it looks like
My
we might.
computer doesn't die. Oh gosh, so embarrassing. I apologize.
Well, my response to that would only be she can have her own webinar, but she can't have Kristen. We're not letting her go.
Well, Kristen will have to come back for DDF to do a nutrition webinar.
Absolutely.
We're happy to have you. It looks like that might be all of the questions so far. And any other remarks from anyone?
Anybody want to make a final remark? Okay, well, on behalf of the team and the Rutgers Cancer Institute in New Jersey, I've been loosely associated with Debbie's Dream Foundation for probably 7-8 years, and it's been a real privilege to be able to work beside them to help out many of the people who come to the foundation for assistance with their cancer journey. We here at Rutgers really appreciate the opportunity to present this webinar and to be associated with the foundation. And thank you all very much for your participation and attention.
Awesome. Thank you so much, Dr. August. And at this time, I'd like to thank Dr. August and our presenters, Dr. Morel Grandi, Dr. Patrick Boland, Dr. Haijian In, I hope I said that correctly, and Kristen Waldron, as well as Michael, our amazing patient, for being on today. I'd also like to thank our sponsors and all of today's attendees. Please visit Debbie's Dream Foundation's website for some of our upcoming events and programs as they are listed here. And this concludes today's presentation. Thank you all so much. And until next time, have a great one.
Thank you very much.
Have a good one. Thank you so much.
Bye-bye.
Bye, everyone.
Bye-bye.